mainly with this sort of memberships that we get from our this sort of members. For fellows, it is only a one-time fellowship fee for the entire lifetime. So, if possible, I request the fellows here that you can talk to your institute. I don't think IISER is still the institutional member, but there are a lot of other major institutes in Kolkata and other parts of Bengal. They are our institutional members. So it will be very nice to get institutes like yours to become an institutional member of the academy. Having said that, this particular lecture is one of the 3 endowment lectures that we organize every year. One is, as you can see here, the other one is in the Earth Sciences uh, section. The other one is in the Mathematical Sciences section. So if there are other proposals for such endowment lecture, we are open to the idea. Of course, it calls for some amount of funding to run this memorial lecture. Typically, our rule is that if anybody wishes to start an endowment lecture, it's a one-time money to be given of 5 lakhs. So, and then it will become an annual feature of the academy. So that also another option of remembering somebody who deserves to be remembered by those who are colleagues or the family members or somebody. So that is another way I call upon you to be part of the academy. Today I am very happy to be here for this program. Last year I could not come because I was out of station on that particular day. But I would also like to highlight here today, which probably many of you don't know, West Bengal Academy is very much present in the social media now. We are present in Insta, but very importantly, we have our own channel in YouTube. And today, as I am speaking, this is being now streamed live in YouTube. So simply you can you have your mobile out and open YouTube and type West Bengal Academy of Science and Technology. Immediately, you can see these people, they are doing this live streaming. We have Professor Ranjan Ganguly of Jadavpur University who coordinates this particular live streaming. And not only live streaming, this entire thing will be archived in our YouTube channel. And I can say today that in the starting from 2024, 25, now 26, about 30 video lectures are now archived in our YouTube channel, which West Bengal Academy has organized. And this one will be added today after this program. So please have a look. And as you know, nowadays it is a practice. I will request you to also subscribe to this channel. It is very easy, just using your Google account. I mean, younger people knows better than me. You can subscribe to this channel. Of course, this has not an entertainment value, but this has some other aspects of this channel. I request all of you to at least have a look at that channel. So we are looking forward to a very interesting talk by Professor Dr. Aggrawal. And personally, I am very much looking forward to this lupus. There is a personal reason behind that, because one of my very close uh, family member, very close as I'm saying, she got this when she was about 13 years of age. And I mean, she was almost not going to survive. But the doctor from our SSKM hospital, one's very senior doctor, I don't know, somebody might be knowing, Professor Jayanta Basu, he saved her. I still remember the day that happened, when that attack was done. I mean, nobody knew. The local doctors, everybody was at a total loss. But in the second day, we went to Dr. Basu, and the moment he saw that young girl, he said immediately hospitalized. He said something, so we hospitalized, and he came, and I was the person who was, that girl's father and mother was almost, very disturbed. So I was almost like guardian. So Dr. Basu called me and said, see, I am assuming, or rather, I'm sure that this is lupus, but the test that I'm going to go do, that will take 3 days for the result to come. But 3 days I cannot wait. If you have to survive, get this girl, survive. So you sign this document. So I will start the treatment just now. Then I signed that document on that day, about some 12 years back or 13 years back, and he initiated the treatment. The very next day, she got seizure, brain seizure. That was almost, very serious condition. But since Dr. Basu started that very day, and after 3 days, it was confirmed lupus. But she survived, and she now works in a software company. She's about 28 years old. So I have personally looking forward to this. What Professor Agarwal has to say, because probably that will help me also to advise the parents to that young girl now. Thank you very much, Professor Agarwal, for coming, and of course, Professor Sinha, thanks for gracing this occasion. Thank you very much.
Thank you, Professor Chakraborty, for the introducing the WAST, because very few of us knew about WAST. When I was told by Dr. Mitali Chatterjee to apply and to get the elected fellow, then I started telling the faculties. But I think we need more faculties to be involved into the WAST program. So thank you for coming, also taking your time within your busy schedule. And now I would request Professor Kole, Professor Arvind Chaudhary, and Professor Datta to come and felicitate our guest of honor, Dr. Arvind Sinha. And sir, you should be here also. Yeah. Please come. And Professor Arvind Sinha is our guest of honor, and he will be introduced by Professor Shibaji Chakraborty. Yeah. একটু ওদিকে যাও, ভালো ছবি আছে। ওটা নেবানো তো যাবে না। Before we start the program, may I request all of you to come for a group photo? Please come. Please come. Please take your seat. And also there will be samosa and tea after the program. So no one should leave. So now I request Professor Shivaji Chakraborty to officially introduce our guest of honor, Dr. Arvind Sinha.
Yes, please have your seat. So it is my very pleasant duty to introduce our guest of honor, Dr. Arvind Sinha. Now, I am of a generation, when we used to do this, we used to bring a piece of paper where it will be written about something about Dr. Sinha. But now I am also trying to cope up with your generation. So I have brought this. I have not brought a piece of paper. Uh, but anyway, uh, Dr. Sinha did his MBBS and later on MS in general surgery and then MCH in pediatric surgery from Maulana Azad Medical College, New Delhi. He has very extensive experience in pediatric surgery starting from 1998 and in multiple very well-known hospitals. For example, Loknayak Hospital, New Delhi, Maulana Azad Medical College, New Delhi, Postgraduate Institute of Medical Education and Research, commonly known as PGI Chandigarh, then Himalayan Institute of Medical Sciences, Dehradun, and also SKHM Government Medical College, Mewat, Haryana. And then since 2013, he is still in All India Institute of Medical Sciences, Jodhpur, where he is now professor and head department of pediatric surgery. And as you all know, since September 2025, he is the executive director and CEO of AIIMS Kolkata. He has multiple accolades to his credit. I am not going to tell all of it, but at least I will be failing in my duties if I not mention a couple of them. He is member, UNESCO Chair of Bioethics, also member, Academy of Medical Sciences, Fellow of Indian Association of Gastrointestinal Surgeons, Fellow of Minimal Access Surgery, Fellow of Association of Indian Surgeons, Fellow of Indian Association of Pediatric Surgeons. These are some of them, some of the accolades he has. And he has very extensive publication record. So I'll just give the numbers. Probably I will be wrong, Dr. Sinha. Please pardon me. International journals, I found about 80. National journals, about 70. Conferences, I think he doesn't like conferences, about 40. And book chapters also 15. So very extensive publication record by Dr. Sinha. And we are indeed very fortunate to have such an, eminent, not only a medical practitioner, but an academician par excellence with us. Thank you, Dr. Sinha, for coming to us. Thank you very much.
Thank you, Professor Chakraborty, once again. Now I request our guest of honor, Professor Arvind Sinha, to take over and hear Professor Amita Aggrawal's talk.
It's a pleasure to be here, and Thank you for the kind introduction. And now it is my pleasure to introduce Professor Amita Aggrawal. Uh, I met her a few days back in AIIMS Delhi, and she was surrounded by 4 or 5 executive directors, and she was holding center stage with a ready smile. So she's always, and I saw the same thing here. She had a group around her. So she's really full of life, energy, and her smile is definitely captivates all of us. So, and about the introduction, the CV is so large that either I can speak or she can speak. so, but to say that Dr. Amita Aggrawal is one of the foremost physician scientists and academic leaders in clinical immunology, and she's an alumni of AIIMS Delhi, where she completed both her MBBS and MD in medicine, followed by DM in clinical immunology. In between, she for kicks, she also did statistics in between, and she's been working in GPGI Lucknow, and she has served with distinction over the last 3 decades, and rose to become professor and head of department of immunology and rheumatology. She's presently, from October 2025, the executive director of AIIMS Bibinagar, and she's internationally recognized. Pioneering contribution on SLE, definitely pediatric rheumatology, vasculitis, and immune-mediated inflammatory diseases, particularly in Indian settings which are resource limited. And she has got an extraordinary academic record, really in awe of the the academic records, and I think she's has more than about, I think, 500 publications, and she has been a key contributor to global consensus statements, classification criteria, outcome measures, and treatment to target frameworks through collaboration organizations such as OMERACT, PRESS, CARA, and APLAR. And she led and shaped Indian multicentric cohorts, including Inspire Lupus Inception cohort. And her work has been definitely recognized by prestigious honors, including fellowships of Indian National Science Academies, National Bioscience Awards for Career Development, and she's delivered ICMR Kashnika orations and Balu Athia oration in pediatric rheumatology. And she's got a distinction in Master of Indian Rheumatology Association also. Beyond her academic achievement, Dr. Aggrawal has been a dedicated teacher, as I have learned, and a mentor and institute builder, really. And she's nurtured generations over the years. And she's strengthened the foundation of immunology in India, basically. And it is therefore fitting and honor to invite her to deliver the SC Bose lecture, endowment lecture. Welcome, ma'am.
So, good afternoon, friends. It's always a pleasure to be back in science institutions because they have a different ethos. And I was in IISER Kalyani about maybe 12 years ago, or 13 years ago. That time it was really new. We had very few buildings here, but it has grown to such a good institution. And I'm so happy to see that. And as I heard from Dr. Kole, that your rankings have also improved. In today's world, rankings really make a difference. Especially the students are looking at that. And if you had good rankings, you get good students. And if you get good students, your output is also good. Sometimes, as we used to say in AIIMS when I joined there, that AIIMS doesn't have to do anything because they get good students, they produce good things. So I mean, the teachers are not doing anything, but I don't agree. That every institution, teachers make a lot of difference. And I think IISER has got excellent faculty, whatever I have interacted since morning. and the students. And I hope to spend some more time with the students in the evening, just to chit chat with them about their projects, because I feel I learn a lot, because I don't do too much good science. Whatever little I have done over the last 35 years, it's not great science. I just did a curiosity science. Today's world is very different. And as I was talking to some people, that how we can move from basic science to translational science. That is what I'm going to talk, a small part of my research, which was trying to find something translational. But at the end, you will see, did I succeed or did I fail? So that's why I've titled it as Where Are We? And I thought it's a good idea to always learn from our past and from pioneers who led the world. So Jayashree has already told you a lot about Dr. Sunil Chandra Bose. And he had lots of firsts to his career. He was the first cardiologist. I always used to think that Dr. Bimal Roy was the first cardiologist, but I was wrong. He was the first one who was trained. And he, from his own pocket, he has bought that ECG machine, which you said that he got the first ECG machine. I was reading a lot more. And that he carried his ECG machine from UK here, because India didn't have ECG machines. And now we think we can go and get ECG done at a drop of a hat. So how things have changed. And it's people like these who make difference. Though he was brother of Netaji, I don't think he ever took advantage of that. Rather, he served all the revolutionaries, looked after their health, treated them. And that's what his major contribution is to the national movement. He founded the Cardiological Society, but he reached to the national level. He was the president of the National Society. He didn't get restricted to Bengal. And he is a man who I think we all need to emulate. How from humble beginning, even though he was from a good family, you need to travel the world. You need to learn. This is for students, that always visit different places, learn and get the good things from there and bring back to your own country. I mean, all of us owe something to our own country. We need to come back and serve our own country. This is what I think I learned by reading about Dr. Sunil Chandra Bose. And thank you, West Bengal Society of Science and Technology and IISER Kolkata, for giving me this honor to give a lecture in his honor. All right, it's amazing. I'm absolutely humbled. I don't think I deserve it. So I'll just start with. So this is, as Dr. Shivaji Chakrabarti said, lupus is a bad disease. It's difficult to recognize, but it's not uncommon. All of us, if you look, will have somebody whom we know has some autoimmune disease. And that is why in my early career, I decided to work on these diseases because I was so fascinated. I saw my first patient of lupus when I was an intern. I still remember her name, Vinita. And I'm still following her up. It's been 45 years. She is with me. So she has been all over the world. She has come back, but it's not a disease which leaves a scar. And that is what prompted me that I did my MD thesis also on lupus because I was fascinated by this disease. And you know that everybody is, I was talking to some students, biomarkers. Biomarkers is a buzzword in today's world, especially in clinical science. Everybody is looking at biomarkers, but it's not that easy. Why are we looking at them? Because we want personalized medicine. Every individual is different. Every individual behaves differently. Every individual reacts to drugs differently. So can we anticipate everything in advance? When it's a utopian goal. Have we reached it? I really don't think so. And that is what I'm going to present. A part of my work, which I did at SGPGI for the last 10 years. And where are we in 2025 or 26? So because we have a heterogeneous audience, I thought I'll give a brief of this disease. So this is our data of 2,500 patients, which we have collected from across 10 major centers in India. And these are symptoms at the start of illness. So this is an inception cohort, which has been built over the last 7 years. And if you see, the most common symptoms in this disease are basically fever, skin rash, oral ulcers, joint pains. Kidney disease is seen in about 40% of patients. You be a child or an adult, it really affects you. And kidney disease is one which really impacts the quality of life. So, how does this present? It can be absolutely asymptomatic. The patient may not have any symptoms of kidney disease. Only when you do tests, you find out the patient has kidney involvement. Or it can be absolutely disastrous manifest. The patient comes to you with a rapidly progressive loss of renal functions and needs dialysis within a period of 10 days. So the spectrum can vary. The patient can also come to you with just unexplained hypertension. Nothing else. The young girl has come to you, suddenly the blood pressure has gone up. It could still be lupus. So it has very varied manifestation even in one organ. Lupus is a disease which is actually a prototype autoimmune disease. It can affect every organ of our body. As Dr. Chakrabarti said, her niece had seizures. So obviously she had involvement of the brain. She would obviously have had many other organs involved because the physician could make diagnosis in no time. Just looking at the patient, the physician made the diagnosis. And so we need to be clearly aware that the autoimmune diseases do exist. And I am so happy that this budget now has recognized that autoimmune diseases need to be included in chronic non-communicable diseases. We were fighting for it for many, many years. And this year, they have agreed to include them in the chronic diseases. We do simple tests to diagnose. I won't bore you with these things. The kidney disease in our cohort affected about 40% of individuals. We could do biopsy in nearly 750 subjects out of them. And if you see the kidney biopsy, it shows you the kidney is actually involved. The glomerulus is infiltrated by inflammatory cells. There is endothelial cell swelling. There's a lot of immune complex deposits. And almost half of these patients have more severe form, which we call as proliferative lupus nephritis. And the rest, 30-40%, have a milder disease. And sometimes when you do kidney biopsy, you also find that these patients have not kidney disease because of lupus, but they have disease because of either a coexisting diabetes, which was never diagnosed earlier. So it is very, very important that if you can biopsy, always do biopsy so that you are absolutely sure that the person has kidney involvement because of lupus, because the treatment is totally different. So this is the data of these children whom we recruited in this study, plus from other international cohorts. And you see that the outcome is not bad. As what you heard from Dr. Chakrabarti, if you treat early, you can make a marked difference. Almost 60% of patients can have complete remission, that their kidney disease stays quiescent for years together. And at least 80% can have partial response. But you need to recognize it early and treat adequately. But in India, the scenario is not as good because the patients come late and we have good amount of early deaths because of late arrival to the tertiary care hospitals. And in our cohort, we had about 50 deaths per 1,000 patient year follow-up. Across the world, lupus has much higher mortality than general population. It varies, especially more in the younger population, because this disease affects young people, generally girls, 9:1. So it really affects the whole family if a person gets affected. And your chances that you will die as compared to general population can be 3 to 4-fold, especially if you're young. And lupus nephritis, if you have kidney disease, your chances of death are even more. And if you have more severe kidney disease, as you see here, that if you have your kidney function has gone down, the chance that your survival goes down to 50% at the end of 10 years. So you need to treat early so that you don't have any scars in the kidney, because kidney is one organ which doesn't regenerate. Whatever you are born with, those number of nephrons will stay. If they get killed, gradually the kidney function will start coming down. That is what happens with aging. Our kidney function gradually goes down. So we need markers. One, to assess risk of nephritis. Among the patients with nephritis, who is likely to get kidney disease? And then, what is the state of the kidney disease? So that we can treat much earlier, we can treat to target, we can also recognize, is the disease coming back? Because if it comes back, it's again going to kill some more nephrons. So we want to diagnose that and also to know the prognosis. So a lot of people work in biomarker areas. A good biomarker is one which should reflect the physiology or the pathology. It should clearly reflect that. It should correlate with renal histology. Because if it doesn't correlate with renal histology, then it is no good. It should be able to predict flares, that the disease is coming back. It should be easy to measure. It should not be a test which is cost you 20,000 rupees. Nobody is going to use it, even though it may be highly specific and highly sensitive. It should not be affected by age, gender, or ethnicity. Then only it will be valid all across the world. Because most diseases affect a wide range of age groups. It should be specific to lupus. Because otherwise, if a patient has other disease, you may have it elevated. That's not easy. We still follow our conventional markers, which have stood us the test of time. They've been with us for years or decades. We take a good history. We examine the patient. We do simple renal function. We look at complement levels, because if they have immune complex mediated disease, the complement will get consumed and the complement level will come down. If they have high titers of autoantibodies, all this tells us the patient has more active disease. Then you look at urine. Unfortunately, in most of our hospitals, urine examination is given no value. Neither in the pathology departments nor the fellows want to look at urine. So that is why we are having problems. Because nobody wants to touch urine. And these are the things this is the change in generations. That those things are not looked at, which are very easy to measure. It is specific to renal involvement, because if you get protein in the urine, it's only coming from kidney. It can't come from anywhere else. It can also tell you sometimes about renal histology. And it can also help you diagnose that the disease is coming back. The only problem with proteinuria is if the kidney gets damaged, then also your membrane becomes loose and the protein will keep coming. So you can't differentiate damage from activity just looking at the protein levels in the urine. So that is a major issue. And because of that, kidney biopsy is the gold standard. But how many of you would like to get a kidney biopsy done? Because it really gives us the full picture. What is happening to the glomerulus, what is happening to the interstitium, what is happening to the blood vessels, how much infiltrate is there, how much is the fibrosis. So you get a really good idea once you look at the kidney. But it's not without complications. So this is a meta-analysis or a systematic review of biopsies done in low and middle income countries. And you see, if you do it blind, 25% risk of some complication. If you do it, mark it with an ultrasound, 15% risk of complications. If you do real-time ultrasound and put your needle along the ultrasound so that you are seeing where the needle is going, then also about 12% risk of complications. So that is why all across the world, people are looking for a substitute of kidney biopsy, especially repeated kidney biopsies, because we generally do multiple biopsies in these patients. So can we abrogate doing multiple kidney biopsies? And that is why urine has come out as a source for looking for biomarkers, because urine really reflects at least the local milieu of the kidney. It's non-invasive. Nobody minds giving a urine sample. People mind giving blood sample because it gives you a pain. It gives you pain. You can develop a hematoma. By providing a urine sample, you don't lose anything. You can do multiple times. You can collect from children. Children are very scared of blood sampling. And it can be transported easily. You don't need to put anticoagulant or something like that. So that is why urinary biomarkers are coming in a big way in patients with lupus, nephritis, and other kidney diseases. Before we go on to what we study, the glomerulus looks like this. You have the T cells, you have the podocytes, and these are the cells which are actually the filtration barrier. If they become leaky, you get the proteins inside the kidney. And you have the macrophages. You also have the resident macrophages in the kidney. So all these cells can produce multiple proteins, multiple factors, which you can measure in the urine. And biomarker discovery can also be that you don't want to go by hypothesis driven approach. You just want to see globally. You can do a non-hypothesis driven approach using proteomics, metabolomics, genomics, anything. All the omics are actually hypothesis free approach. They sound very nice. In my career, I tried all of them. You always get fascinated as young, and later you realize it's not great. It's so difficult to analyze the data, and you get so many false discoveries, and then you try validating each of them. You can spend your lifetime, and still you don't reach anywhere. So I will tell you my failures first, and then we'll see what we did later. So I started with first looking at what are the things which can increase risk of renal disease. So we had this because you cannot do any of these things unless you have good large data set. You need to have good quality data which is available on large numbers. Then only you can look for anything to be predicted. So this we did on these 2,500 patients. We did about 18 autoantibodies in these patients and try to look at autoantibody clusters. That can different autoantibody clusters define different phenotype in these patient groups. Because we know that autoantibody development is partly dependent on your genetics. So if you see here, that the cluster 1 has higher risk of having kidney disease, both proteinuria and proliferative nephritis, while the other 3 clusters actually were protected. So if you have antibodies to DNA or DNA related proteins, that is histones, nucleosomes, or double-stranded DNA, you are more likely to get kidney disease. So this is one of the predictive factors for developing lupus nephritis. We haven't yet done genetic susceptibility. We have samples of all these 2,500 patients. Anybody of you who's interested in looking at genomics is most welcome to use this biorepository and tell us what are the risk factors for developing lupus nephritis. Looking at disease activity, I'll start with our failures or partial failures. That is a non-hypothesis driven approach. So we started this in about 2016. We took 10 subjects who had active renal disease, inactive renal disease, healthy controls, and patients who had really good lupus but no kidney disease, because we wanted to find out a marker which is specific for kidney disease. So we ran the 2D gel, found out the differentially expressed proteins. So we chose these 3. So these we did not see in inactive patients. We did 10 each, and whatever was there in all the patients and not there in inactive disease or healthy controls, we chose those spots and we analyzed them by multi-top, and we could find out that there were 3 proteins which we got interested in. How did they behave? So after that, we did ELISAs for those proteins. One was retinol binding protein. Here we took one disease control, because any proteinuria like diabetic nephropathy, it's not an inflammatory disease. It is not lupus. But we wanted to have a control. That these are markers, what we are defining is disease specific or not disease specific. And we found that retinol binding protein, actually the highest levels were seen in diabetic nephropathy. Even though it was very high in patients with nephritis and it could differentiate all the groups of lupus, but it wasn't specific for lupus. Then you have alpha-1 chymotrypsin. This is a protease, and this had highest level in active nephritis. And when we did the ROC curves, they performed better than the conventional markers of complement levels and anti-DSTA, and also proteinuria. So these 3 markers were good. But the problem with these, why we didn't carry further, because these assays were so expensive. Getting ELISAs for alpha-1 anti-chymotrypsin is very, very expensive. We realized that we haven't identified anything which is cheap. And retinol binding protein, even though it was a little cheaper, it is not specific. They had good correlation with renal activity. Like we use a measure of renal activity. They had good correlation with that. Then we thought, okay, we have a Center for Biomedical Resonance in our institution building in the campus, CBMR. So we asked them that, can you look at metabolomics and tell us, does the urine have anything different? So what they could find out, that if you see lupus nephritis before treatment and healthy control was partly segregating out separately, and after treatment it was coming near normal but not totally normal. So there is a lot of overlap. And that is what we saw, that when you treat these patients after 6 months, the levels came partly to normal levels. But how many people will have NMR spectroscopy? And that's why I said I have done mostly curiosity driven research. How much impact does it make? I don't waste it. And then we thought that, can we identify one marker out of this metabolome? So we looked at urinary citrate because that was one good marker we could find. Because lower in patients with lupus nephritis as compared to healthy control. And once you treated them, the levels came up almost to the normal level. So citrate is a good thing. But when we try to validate, the values were, if you take the same patients at 3 different days, the values came different. So metabolic alterations happen so quickly that to really think that they will become really a good biomarker was very difficult. Because the diet can change your citrate level. Your other things can change your citrate level. The drugs you take can change your citrate levels. So that is why we had to drop this idea. So after that, we thought, let's do hypothesis driven. Because this non-hypothesis driven thing is not giving us a biomarker, which is really great for patients with lupus nephritis. And we all know that, as I showed you the immunofluorescence picture, that the kidney biopsy has lots of immune complexes deposited. So complement activation products, complement activation will occur, and you will have complement degradation products. And C3D, after the complement activation, C3D is a very stable protein. Because most of the complement proteins are very labile. Their half-life is only about few minutes. They disintegrate further. So C3D is much more stable. So we tried looking at the C3D levels in patients' urine, and we saw that the patients who had active nephritis had much higher levels, and healthy controls had very, very low levels. And patients who responded, their levels came back to normal, while patients who did not respond, their levels did not come back to normal. So this had a fairly good correlation, and the area under curve was also very good. This is the ROC curve, which tells you the sensitivity specificity relationship. You could get up to 0.87. So that was not bad. The only issue was that the company stopped making that anti-C3D antibodies. So we found it very difficult to get more antibodies to coat on the plate. Because there are very, very few companies which make complement degradation products based these chemicals. The other thing which all of you are aware and know, that lupus is purely a type 1 interferon driven disease. It's like as if you've got a viral infection. Because there in the viruses, it happens because you get exogenous RNA and DNA from the virus. While in lupus, there is a lot of extra DNA. Because the DNA removal machinery is off. Our scavenger receptors go for a knock. So they don't clear up. The DNA's enzyme level goes down. So the DNA does not get degraded. So there is increase in both intracellular as well as extracellular double-stranded DNA. And that drives the C-gas skin pathway and can cause type 1 interferon response. And type 1 interferon response normally we are measuring by looking at mRNA levels of certain proteins. And that gives you an interferon signature. But in clinical practice, can you ever think that we'll collect sample for RNA, separate RNA, and then try to make a biomarker which is based on mRNA levels? It will not happen. So what we looked at was the protein which are secreted after you have type 1 interferon response. Because these protein levels increase, so we chose CXCL10. So CXCL10 is also called IP10, so it is an interferon inducible protein, and galactine 9. These two proteins are produced in response to excess of type 1 interferon. And you could see that lupus patients had much higher levels in the serum, urine, both of these. And the serum levels were fairly modestly good to assess activity. But when we went to the urine levels, no difference. There were not significant difference between patients who had inactive disease, active disease, or active non-renal disease. So it looked at it's the serum proteins that are getting filtered into the urine, and the urinary levels are not reflecting the renal activity. It is just that it is getting filtered out, and what we are measuring in the urine is just reflection of the serum. So it's not a great marker. Can we do something which is coming out of lymphocytes? Because as I showed you, the glomerulus, the interstitium, everything is infiltrated with immune cells. And most of them are lymphocytes. So when a lymphocyte gets activated, it expresses this molecule, IL-2 receptor alpha, which is CD25. And that is shed off once the cell gets too much activated. So you can measure soluble levels of CD25 both in the serum and urine. This is actually the urinary levels. And you see that patients with active nephritis have much higher levels of CD25 as compared to inactive disease or non-renal disease or healthy controls. And these levels come down when you feed the patient. So this is a 1-year follow-up studies which show that the levels gradually come down. But patients who do not respond, their levels do not come down. So soluble CD25 is a fair marker. I'll show you our validation data later on of this marker. And recently it had come that in US they had done 1,000 protein-based proteome to look at urinary biomarkers. And they identified IL-16. This is a cytokine which actually activates the T cells and causes CD25 to increase. So because we had already seen that the CD25 is increased, so we thought that can we look at IL-16, which is much easier to measure. But IL-16 levels though were higher in the urine, but they were not very good. So it had a very low sensitivity. It could be detected only in a proportion of patients. We looked at other T cell derived cytokines like interferon gamma, IL-6, IL-10. They didn't perform as good. So I'm telling you the story that it's not easy to get biomarkers. It's a hard task. Then we've also looked at the B cell related proteins. BAF and APRIL are the two proteins which are needed for B cell maturation as well as sustenance of B cells. So both the levels of the BAF and APRIL are increased in urine and they actually performed well. The levels came down and responders had much more decrease than, but the numbers were less in this study. So we can't actually make out too much that can it be a marker for response or no response. What I'm more excited by is this, the macrophage based marker. Because if you see these macrophage based markers, that is macrophage chemotactic protein 1, it had really marked difference in the level. It had very good correlation with renal activity. And it also came down with treatment. It's also produced by the glomerular cells, but it was not specific for lupus. When we looked at other glomerular diseases like IgA nephropathy, other ones, you could see it in that. But then we decided that we will never get a specific marker for lupus. But because diagnosis is not made on this, we have already made a patient has lupus. We are trying to find out if we can find activity marker. So we gave up our quest that we are going to find a marker which is specific for lupus. But if it performs well, it will be good for us. And we also found that it is more for class 4 lupus nephritis. Then we have done a validation study now for this marker. This is in larger subjects. That was in about 100 subjects. This is 180 patients with lupus. Again, it has done very well. So the levels are very high in lupus patients. They are much more in active renal disease. They correlate very well with disease activity, both overall and this. They come down with treatment and it gives you a very good area under curve when you look for differentiation between active and non-active disease. So we think that this is a fairly good marker. And we also looked at histology to look at how much is the macrophage infiltration in the kidney. It is immunohistochemistry. So the activity index in the kidney biopsy had fairly good correlation with the amount of urinary NCP1, and it also correlated with how many macrophages were there in the kidney biopsy. So it is giving us how much is the macrophage infiltration in the kidney biopsy. A surrogate of that you can measure by looking at MCP1. So we looked at another marker, as you people who are from immunology would know that there are two kinds of macrophages, M1 and M2 macrophages. M2 macrophages are the more anti-inflammatory macrophages, but they cause a lot more fibrosis. So they are bad for a chronic disease. So this one actually performed better than MCP1. And there the level difference is almost 100-fold. Patients who have active nephritis. And their levels also come down with treatment. And again, it showed all the good correlations, everything. And here the area under curve was 0.91, which is excellent. For a biomarker, if you can get area under curve of 0.9, above 0.9, you are very, very happy. The soluble CD163 actually gave us the best results, both in the discovery phase as well as in the validation phase. And this difference is about 7-8 years in between. So it has stood the test of time. And we also looked for kidney biopsy if the CD163 macrophages are there. So there's good infiltration of CD163 macrophages both in the interstitium and in the glomerulus. And there is a really good correlation between the number of CD163 macrophages and the amount it is excreted in the urine. So it correlated with histology. It told us about the macrophages. It was a robust marker because we could validate in 2 different studies with large number of subjects. It correlated with the activity score, which we do by usual histology. So these 2 markers we feel are good markers. Then can we look at cells? So we tried looking at lymphocytes, but urine is full of debris. You need to get the live population. You need to be sure they are lymphocytes. So you have to do a live state. This is showing you that only 0.46% cells are actually T lymphocytes. Because we are a poor country. Can we look at lymphocytes by not looking at flow cytometry? And we found that there is a stain, Kovacs stain. You can make a suspension of the urine, centrifuge, and stain it with this stain and count the number of lymphocytes. That's a very cheap test compared to staining the cells and using a flow cytometer. And what we could find in this was, let me see, these 2 scatter plots look fairly similar. This is looking at by flow cytometry and this is looking at by that stain. And if you see area under curve for both of them, very good, nearly 0.9. So you can use simple things. That is what, when we had discussion in the morning, I said, what the government is looking at. Can we do something at a low cost so that we can implement it in our country? And it had very good correlation with lymphocytes and CD3 cells. It could correlate with activity, renal activity. And you could also see the CD3 cells are present in the skin and they have a good correlation. So these 3 things actually have shown that they correlate with the histology, they correlate with the number of cells, they correlate with response, and they are robust. And this is the change in lymphocyte numbers versus the change in activity. You see such a good correlation. Then just to look at what are these subsets of T cells, we tried using multiple markers and we found that CD8 cells were much more than CD4 cells. And actually CD8 cells had a better correlation than CD4 cells. So this is a recent study which has collated all the data across the world. Like, what have we learned from these urinary biomarker studies, which have been done at least at 4 or 5 centers across the world? Chandra Center at Cincinnati is one group. So this is a review written by Chandra group. Then there is another group in UK, in Manchester, which does a lot of studies in pediatric lupus. And there is one more center in Canada. Like 3 or 4 centers across the world which concentrate on looking at lupus urinary biomarkers. And if you see, actually CD163 giving you the best area under curve, 0.9, 0.92. In most, whatever studies, 4 or 5 studies are available. And similarly, NCT1. NCT1 has been validated across many studies. While rest of them, you have 1 or 2 studies, not more than that. So my feeling is that these 2 markers probably are good markers It can be easily measured and can be utilized. So then we thought that should we make a composite score? We have some good markers, soluble CD25, CD163, MCP1. So we tried doing a composite score for these three biomarkers. With that, obviously, when you do three biomarkers, your area under curve increases. And this is for the test training set, and this is for the testing set. So even in the testing set, it still stays nearly 0.9, means it's an excellent discriminant. Then we thought that can we reduce it from 3 to 2? How will just two biomarkers perform? So we did only the monocyte-based biomarkers. They have done fairly well. So what we have come to conclusion at the end of all these 10 years of these studies, that probably just doing CD163 and MCP1 in the year is good enough to give you a handle on looking at activity of disease, correlation with renal disease, also with histology and with cellular implication. And this is paper which got published just recently in October 2025. And again, you see CD163 and MCP1. These two markers are correlating very well with the histological findings. Because the bigger the size, the bigger is the value. The only other thing which is coming up to that level is the antibodies to C1q, which is antibodies to the complement protein. So I feel we are near the post, but we haven't reached yet. None is perfect. Probably we need a composite score. Our feeling is that these two are good. These are macrophage-based markers, but we haven't done multicentric studies in this. We need longitudinal samples over long periods of time. Maximum I have done is 1 year. 1 year is too little in the life of a patient of lupus. They live for 40 years. We haven't done really good prediction of flares because flares will happen over time. You need to collect samples over time, and only you can say that were you able to detect a rise before the flare happened? Then only you can keep them early. And can we use them to detect lupus nephritis in patients who are asymptomatic? We haven't done those kinds of studies. Because for that, you need to do biopsy in everybody. Then only you can be sure that they had it. And also we need to see that if you measure these, would they have over 5 to 10 years a decline in renal function? Because ultimately, what are we doing? Our aim is to save the people. That they should not go into end-stage renal disease, which happens in about 10 to 15% of patients over 10 years. And we need to make a single tube assay. Because if you want to translate it to a clinical lab, it can't be that you're running multiple tubes, multiple things. It takes hours or days to give the result. As sir said, so the doctor said it will take 3 days for the test to come, but I need to treat now. So you need to have a single tube assay. So this is one paper which I thought was I should discuss because you people are technology people. So what they have tried to do is they have made a multiplex read assay. Their composite score actually involves 6 proteins. This is a rail score that has been tested in 2-3 studies. But you see here, for 2 of them, they could not make those beats out of 6. They could make beats only for 4 proteins. So there is a lot of technology needed. That can you get soluble CD163 and MCP1 onto the particle to make a single tube assay. You can either make it in an ELISA format or you can make it in the flow-based format. So no work is done alone. It's my team. So these are the students who have looked after these patients for the last 10 years, provided me samples. And this is the photograph taken at my retirement on 31st December 2025. These students I have trained and they've really helped me get samples. It's not easy. Very, very difficult from patients to get samples because we need 100 ml urine, not a small sample. And the SLE patients who helped me learn this disease, they are part of my life. So we have a support group, the Inspire Project Lupus, and the Department of Biotechnology for funding me all through 2 decades for the lupus projects. Lupus projects are predominantly funded by Department of Biotechnology, while arthritis projects are predominantly funded by ICMR and my institution. It provided me the space and the liberty to do what I wanted. And thank you for your patience. Oh, we can have questions. Yes. Students. Yes, sir. Oh.
Great lecture, ma'am. It was really a learning process. So I have two questions. So when you did that metabolomic study, so did you get any kind of hints like which kind of metabolic pathways are getting affected in these patients? And the second question is that when you at the end about the biomarker thing like MCP1 and CD63. Now MCP is a very generalized inflammatory marker. So are we looking for any kind of particular ratio in these two markers that can detect the lupus thing predominantly?
So as I said that we gave away the quest for having a lupus specific marker because we couldn't find. We had looked at almost about 30, 40. All of them you would find in some other glomerular disease or in diabetic nephropathy or in something else. So then we thought that we are not diagnosing lupus by looking at urine, these levels. Because diagnosis of lupus is made by looking at patient, other tests. So we already know that the patient has lupus. So then we thought that whatever gives us, I agree absolutely with you that they are inflammatory markers. They would be there in many other diseases. But
No,
if
might be some ratio is very important, particularly for lupus.
so ratios is not very important because what happens is that if you saw the kidney biopsy specimens which I showed you, you have both M1 and M2 macrophages there. Maybe if you see longitudinally, it could be that initially there were lots of M1 macrophages and gradually over time they have moved to become M2 macrophages, especially after treatment. But doing kidney biopsies again and again is not possible. You can study it in animal models and see that do these markers change over time in animal models or not. So that's a good suggestion. I can talk to NII. They have animal models of lupus. So they also have the MRL LPR mice model. So if they can see when the kidney, because they have spontaneous disease. So in them, does these markers change over time as the lupus nephritis progresses? But in humans to do issues again and again becomes very difficult. So what we have done is we have just given weightage. In that composite score, there is a certain weightage for MCP1 and certain weightage for soluble CD163. And then we have just done an equation. And whatever equation gave us the best discrimination, that is what we are using.
And last question that you have a very long-term research interest on this topic. So over the years, did you notice anything that with these lupus patients have any kind of like changes into the cardiac activity related things?
Yes, the most important cause of death, like this is our initial data because this cohort has been there for about 6 years, 6.5 years. So what we have initially presented is the early mortality. The early mortality is all because of severe disease. And second is when we give them immunosuppressive drug, they die of infection. So in our country, infections are a major source of this. But long term, the most important cause of death is cardiovascular morbidity. So cardiovascular morbidity is a major thing because they have continued inflammation. As you are seeing, macrophage markers are all
That is the reason I asked.
They will cause increased subclinical atherosclerosis going into full-blown atherosclerosis and they die of myocardial infarctions, especially young females.
Thank you, ma'am.
You work on cardiovascular disease, I know.
Yeah, that's why I asked, like,
Absolutely.
is there any big connection on that?
So the molecules you work on, those have also been looked up in lupus. So you are basically work on certs, no? Sometime that. So that also G proteins, yeah. So they have also seen that also. So those definitely get affected because the whole milieu is so much pro-inflammatory. That's why.
So excellent talk, ma'am. So would you call these a diagnostic marker or prognostic marker or both? These two panels.
So, at present, I don't think I should call anything That's what I said. I am presenting not a full success. I'm just telling you that what are the issues which happen. Youngsters should know that science is not yes and no. Science is a lot of hard work, lots of failures, and when you make conclusions, you should be absolutely certain. So for these 2 markers or 3 markers, we have done it 3 times over a period of 7 to 8 years. I can say now, because we have done 2 times correlation with immunohistochemistry also, because I want to be sure. If I'm not sure, I don't want to speak. So at present, we can only say that this is a good marker for activity of disease. It is obviously not diagnostic, as what Viswajit said. They are not specific for lupus, so they cannot be used as diagnostic markers at all. They can only be that instead of doing kidney biopsy, you can say that if these are elevated, it's most likely that there is active disease inside the kidney, and you can follow them up. If they don't come down, it is that likely that the patient has not responded. But we have not done a second biopsy. That is the next plan. The person whom I have handed over these projects, that we will do protocol biopsies every 6 months and see that do they correlate even after therapy. The people who have higher levels, their activity is high, or people who have lower levels, their activity has come down or not. So it's too early to say anything at this stage.
So, it's a very nice talk. So, do you have any RNA-seq data for tissue or serum samples? You showed that proteomics and metabolomics. So, any RNA-seq data? Okay. Yeah.
The biorepository actually has the samples stored in Trizol. For 250 patients, we have serial samples collected every 6 months, along with their urine samples, along with their serum and plasma samples. So this is for you people to utilize them.
So, I have another question. So, in your slide, there is a train and test data sets. What are the sizes of these 2 data sets?
So these are about 100 each.
100 each. Okay. And do you have a plan to do AIML model for these?
The problem is with 100 samples.
No. Any other web-based data, if you have?
So we have web-based data for this whole cohort.
Yeah.
We have about, I should say, we collected maybe about 200 parameters per patient. Clinical, demographic, autoantibodies, their lab tests, their trajectory over time. So if anybody is interested, it's available to everybody. We are one persons who do not want to not share data. Everything is anonymized. It is fully anonymized. I've been telling DBT because the only drawback which we faced was COVID came in between. So those 1.5 years, it was, you couldn't be, we tried doing teleconsults, tried doing everything, collecting as much data as we could during that 6 months. So that has partly vitiated because patients did not have access to drugs. So they defaulted on the therapies. They could not come for follow-ups. So that is actually, I feel so sad that that cohort was going so well, and that 1.5 years we really have. But the baseline data is, you can get anything. And if anybody is interested in genomics, because genomics, you need only the baseline data of their phenotype and what happened to them over 5 years. So that will be good to do. The DBT is ready to fund. Actually, the problem is because I was retiring, so I couldn't write any more projects. Because they stopped 3 years prior to your retirement that you can't apply for projects. So for the last 3 years, I couldn't apply for any project. But they are very, very willing. Anybody who is interested to do genomics, because they say don't partner with the private people. I have a person who's ready to do free, who's ready to do 2,500 exomes free for me. But the government is not very keen that we should give it to the private people. They want a government agency to do it.
Madam, it's excellent work, madam, it's long work. So I have just small experience in IGIB's institute. So there is also rheumatoid arthritis model, and similarly at that time 2004 around I did, and this is 2D gel electrophoresis as you rightly told. So there also we got that LDL and VLDL changes as per the compared with the controls. So do you think with your vast experience, is it possible to do something on the lipidomics area to get some clues?
Why I'm not so excited about lipidomics is that it is so very
Yes, yes, that is true.
It just keeps changing with time.
Yeah.
Unless something, as I said, that the biomarker needs to be a little bit stable.
No, is it like that, that it is the stage-specific lipidomics change occurs in the disease?
Definitely. Definitely.
So
there's
is
a
it
change
that,
in
is it,
operation
if it
of
is that,
lipids.
yes,
Operation lipids do happen.
yeah,
It happens both at cellular level, people have shown, even at cellular level, there is a change.
yeah.
And at the whole system level. The problem, what I face is that if you do the same test 3 times,
Several times, biological variations will be there.
biological variation is,
That-
and the diet makes a lot of difference.
Yeah,
It really makes a lot of difference. So that's why I gave up looking at metabolomy, because you can't control diet. And then they wanted us to collect samples fasting. The patient doesn't want to come fasting.
yeah.
The patients come from far off. They say, sorry, we can't come far. Only patients whom you could collect samples were ones who are admitted in the ward. Even there, sometimes they will eat something at 5 a.m. in the morning. So that is a major issue with.
So,
many
so
of these
yeah,
young
we have
doctors.
seen in the synovial fluid, not in urine, the synovial fluid, we have seen that 2D electrophoresis shows that LDL and exactly LDL and VLDL changes. So that is very interesting. That time I felt, but we could not pursue this because of the same reasons, because of the, yeah. Yeah, well, thank
So
you.
we also tried doing synovial fluid. Also, we tried
Yeah.
looking at 2D gel. And
Please restrict
Yeah.
to one question.
Excellent talk. Only one query. The galectin 9 that you found out, whether in that composite score, MCP and 160T, can we add that one to get more specific thing?
so what I showed you, maybe I have it through that. The galectin 9, urinary galectin 9 did not perform. The serum galectin 9 was different. When we did that in urine, next slide, did not perform well, and it did not show any correlation with the histological score or the disease activity. That is why we have not. Even though pathophysiologically it looks the best. Because type 1 interferon is the most important pathway in lupus. So that is a major problem with biomarkers. Sometimes they just don't go hand in hand with what we believe is the major pathology.
Thank you, madam. We'll talk later.
In the outset, you have told that this is a disease where the both intracellular and extracellular double-stranded DNA is more. So, is the literature there is some evidence that the circulating cell-free DNA level can be a marker? The disease activity, if there is a flare.
The thing is that in lupus, not only the circulating DNA, because all the intracellular pathways mostly get activated by intracellular. So your C-gasping pathway, your TLR7, TLR9 pathway, which is because of endogenous RNAs, they predominantly get activated by this pathway. But some contribution is definitely there of extracellular DNA. So I have not seen much studies where people have measured, because cell-free DNA is predominantly being measured for malignancies.
Yes.
Because there you can look at minimal residual disease, or you want to see that how is the
Liquid
starting
biopsies.
and those things.
Good evening, ma'am. Thank you for your enlightening talk. Madam, as clinicians, we often face a conundrum where patients who are presenting with lupus nephritis, often there is a lot of heterogeneity in their response to drugs. As we all know that most of these drugs which are being used in European and American countries, it is still not available. And we are still very much reliant on cyclophosphamide and mycophenolate mofetil. Did your study, madam, at any point of time consider how we can predict which patient is, which subset of patients is going to relapse on cyclophosphamide, not going to be a responder on cyclophosphamide, and the role of these markers?
Of course, we have not stratified according to the therapy. We have done a previous looking at pharmacogenomics of cyclophosphamide, because cyclophosphamide is drug which the drug gets activated as a cytochrome P450 to the active drug. If there is a difference in metabolism, then if you don't have active drug, less of conversion to active drug, you're less likely to get response. That is what we had found, that some of those isoforms of cytochrome P450, there is a genetic polymorphism in them, which convert the pro-drug to active drug less. They were poor responders as compared to people who converted into more. So we also did their levels pre and post after giving cyclophosphamide. We found that that is a good thing. Because genetic markers are much better for drug response, because they are stable. They are there from birth. You can see them. Because what we are looking at, whatever studies I have done, of this genetic study, is that you can see response at 3 months and say that can the 3 months decline in these values predict response at 1 year? Definitely. But we did not stratify by that. But maybe we can do it now. We have enough.
Thank you.
It's an interesting talk, madam. I have one question related to, you talked about the renal activity. Is it the same physiological changes of the some kidney physiology like glomerular filtration rate or creatinine like that, or some other else? This is first question.
So renal activity can be measured in the clinic. They are measuring by looking at urine proteins and serum creatinine. So they are usually available. But kidney biopsy, you can look at, is there an inflammatory infiltrate? That gives you a score in the category. Is there a hyaline thrombi? It gives you a score. If there is a proliferation, you get an extra score for activity. For damage or chronicity, we look at, is there a fibrosis in the interstitium? Is the vessels showing intimal hyperplasia? Is again a chronic thing? Are the tubules atrophied or some of the glomeruli are lost? Those 4 are taken as markers of chronicity. And there are markers for activity. And this is supposed to be really equal. It has been there. So that is a renal activity. And renal activity,
is it the same marker like any chronic kidney disease or drug-induced kidney disease?
Drug-induced kidney disease predominantly affects the kidney. The affection of the glomeruli is much, much less in drug-induced. Where the markers generally are used are tubular proteins like KIM1, NGAL. So those proteins are used as markers for drug-induced kidney disease or acute kidney disease. While this is basically because of the inflammatory pathology, we are predominantly looking at inflammation.
Thank you.
Good afternoon, ma'am. So enormous amount of like work and like you can see here. So I have a little bit.
Still, we haven't reached anywhere.
So I have actually a different type of question. Like when you are working on these like markers, like and they are actually you're looking into the activity of the kidney or flare-ups. So my question is like it is clearly has a biasness to women. Women is it's like more affected. What happens in the kidney when it's early onset and it's detected, and if the woman reaches at the reproductive age, what is the because I know someone who has a difficulty in childbirth because she has lupus. So what is happening in case of those women who has an early onset, detection, and whether this can be a surrogate marker for like identifying like some other reproductive issues or something.
So if you see lupus, if it occurs in children, it definitely has a worse prognosis.
Okay.
And most of lupus occurs in young women in their reproductive age. But if your disease is controlled and you do not have end organ dysfunction, that your kidneys have not got damage, your heart and lung have not got damage, then the success of pregnancy is pretty high. We have managed maybe about 300 to 400 lupus pregnancies. We have lost some of them, definitely, because it's a disease which is very unpredictable. It can flare up during pregnancy and you will lose the baby. Sometimes you can lose
actually that happened like in
that's what I'm saying. It can happen.
The case I know.
So the basic thing is that have pregnancy when the disease is controlled for at least 6 months to 12 months. You are on minimum doses of drugs, you're on safe drugs, and you have a regular follow-up. That is the key. But still, it's not 100%.
Thank you.
Yes, sure. No?
Thank you, madam, for your nice talk. Actually, I have a very simple question. Means the message for the common people. Means what to do to avoid the disease or how to understand that it is there. Means awareness type of things, if you can suggest.
We have made a poster which we wanted to put, and we have put it in some colleges or places, waiting halls. So when to think of this disease? Because we want early diagnosis. Actually, if you see the study we did for looking at what is the time period for patients to get diagnosed with lupus, India is doing very well. Our median period came out to be 6 months in metropolis cities and about 9 months in other cities. Whichever centers we had actually done from 30 centers across India, that whatever patients came, they had to tell us, when they had to fill up that performer, that first symptom to diagnosis of lupus. If you go to the West, it is 24 months because their system of referral takes so much time to reach the specialist. Anybody can walk across to AIIMS Kalyani. He doesn't need any referral. If a patient has a typical disease, like Sir said, if you have a rash, it is typical of lupus, it will be 1 minute diagnosis. If patient has multi-system disease, multiple organs involved, young female, you will think of lupus. So there are many, many things. Like young lady comes with renal disease, they will always exclude lupus in that patient. So in our country, it's much, much less. So think of it when you have young female who has hair loss, oral ulcers, skin rash, has kidney disease, has low hemoglobin, low platelets, or gets seizures, we always think of it. But still, it's a rare disease. Don't think of it in every patient. Rule out common disease. Don't overburden society by doing unnecessary tests. Malaria can give you all these things. So first, rule out common diseases, then think of them. Thank you.
Thank you, Professor Agarwal, for the wonderful talk. And we learned a lot from your talk, like, what we think about the biomarker. We generally say very easily, like, for writing grant, that we are looking for biomarker. But I have realized that that is a mistake, like, how much data she showed, which gave the negative result. So looking for biomarker is a challenge. So that's the thing we learned from her very well. Like, and thank you again for taking the time and giving the wonderful talk. Now I request our like dignitaries to come on stage. Sir, please come. Dr. Arvind Sinha, Dr. Shivaji Chakraborty, our head of the department. Listen, to felicitate Professor Agarwal for her wonderful work throughout her 35 years. And though she retired, but I think she didn't retire from her work. You can see the level of enthusiasm she has. So she is a big inspiration for all of us. And I must take this opportunity to say, when I came back from US to India, I was not recognized at all for my work. But Professor Agarwal gave me the the stage to explore, and she introduced me to different funding bodies, and especially the DBT for her gave me the board of governors position. And also, for grant, they recognized my work absolutely for her comments. She always gave very good comments to my grant, and also she encouraged me. She told me after the task force meeting, Jaishri, keep up with good work. I think we need people like that, like her, that who can encourage the youngsters so we can also perform well. So thank you, ma'am, again for your significant contribution in my career. So now I request the I must thank everybody. And
I never feel bad if your grant gets rejected. Failures are part of life, and don't blame the task force members. That so we keep hearing everybody says, "Oh, my grant was rejected. They didn't do." Actually, you should see how much effort task force members put in. So much effort goes into it, and we also are fallible. Sometimes we do mistakes. A good grant does not get through. Sometimes that they are just at the border. The funding agency says we have only this much money. We keep pushing, please, please, this is good, but they don't have money. So don't think that if your grant did not get money, that it was bad. It was good, but it didn't reach this level. and you try it out. Next time you will make it. All the best.
Now it is my job to give the vote of thanks. But tell you the truth, like, in the vote of thanks, there is not much. I already mentioned, like, who contributed significantly. And now the students who are really working in behind the screen, like for live streaming and that, live performance of her talk. So Mr. Shovik, Mr. Shubhadeep, Anushka, and the entire JDS lab. So a big thanks to them. And again, thanks to IISER Kolkata and WAST for giving the opportunity to host the program. Thank you all. Thank you, Dr. Aggrawal, for taking your time and come all the way in your busy schedule. She is the director now, so we know how much work she has. But she came yesterday night and she will be leaving tomorrow morning. And my sincere thanks goes to Dr. Arvind Sinha, the AIIMS Kalyani director, for also, like, she took, even I know she was in a big meeting, but she came here. And our the president of WAST, Dr. Shivaji Chakraborty. With that, I may conclude the session. And I hope next year also IISER Kolkata will get the opportunity to host and we find a speaker like her. With that, goodbye to everyone. And there will be tea and samosa and the sweets.
লিভ কল লিভ করে দেবো